The next session is in the continuation of the previous session only, the part B of INMA Gastroparesis, Functional Dyspepsia, Cyclical Vomiting Syndrome Consortium. And for this, as moderators, I would like to invite on the stage Dr. Sanjeev Sachdeva and Dr. Arvind Khurana. And as chairpersons, I would like to invite on the stage Dr. Pankaj Singh, Dr. Anirudh Singh, Dr. Bimal K. Sahu, and Dr. Arshdeep Singh. I would request our moderators to call upon the stage the respective speakers.
So in this part B of this gastroparesis session, first talk is by Dr. Nitesh Pratap, who is a senior consultant at KIMS Hyderabad and also secretary INMA. So I invite Dr. Nitesh to deliver a talk on medical management of gastroparesis.
Good morning, everybody. So today I'll be basically talking on medical management of gastroparesis, and Dr. Puri will subsequently talk about the endoscopic therapy. So I'll be mainly concentrating on the medical management. So gastroparesis, as we all know, is a syndrome which is characterized by nausea, vomiting, early satiety, abdominal discomfort in patients with delayed gastric emptying in the absence of mechanical obstruction. 50% of these cases are idiopathic. Diabetes is the most frequent systemic cause. Other causes include post-viral infections, post-surgical damage to vagal nerve, and medications, which include anticholinergic, calcium channel blockers, antipsychotics, and diabetic medications. So, when you evaluate these patients, you have to first exclude a mechanical obstruction by doing an upper GI endoscopy. And if you are suspecting an upper small bowel obstruction, you might have to do a CT or MR entography. The other evaluation is to assess the gastric motility by looking at scintigraphy, breath test, and etiological evaluation, which includes antroduodenal manometry and EGG. Scintigraphy usually you do with a technetium labeled low-fat protein meal. And in these patients, if there is more than 60% retention of the meal at 2 hours or more than 10% at 4 hours, you call it as delayed gastric emptying. And based on the percentage of emptying which is delayed, it can be mild if it is 10 to 15%, moderate if it is 15 to 35, and severe if it is more than 35%. Breath test has been used with a specificity of 80% and a sensitivity of 89%. EGG, that is electrogastrography, has been done in these patients, and they have been shown to have a lot of gastric dysrhythmias, and there is low percentage of normal gastric wave, and higher gastric dysrhythmia has been seen in almost 75% of these patients. Antroduodenal manometry has also been done in these patients, and mainly this helps us to differentiate between the myopathic as well as neuropathic patterns, because on myopathic disorders we'll have low amplitude, less than 40 mm for gastric and less than 10 mm for the small intestine, but the coordination, the contractions will be coordinated, while in neuropathic it will be more of uncoordinated contractions and absence of migrating motor complex. So, if a person comes to us with a typical history of nausea, vomiting, and postprandial bloating as in this setting of a gastroparesis, we usually do a scintigraphy to assess the gastric motility. If there is a known etiology, you treat it. If unknown, you'll do the other basic blood tests like sugar, protein, thyroid, and ANA. And if you don't find any etiology, we'll do a gastroduodenal manometry to look for whether it is a neuropathic or a myopathic pattern. Now, coming to the management of these patients is multimodality. You have to look for a nutritional therapy, pharmacological, endoscopic, and surgical therapy. So, the main goal of therapy in these patients is to correct the nutrition deficiencies, give relief of the predominant symptoms, and basically try to improve the gastric emptying by treating the underlying cause, and reserve invasive therapies for severe and refractory cases. So, coming on to the first one, that is the nutritional management, it is very important that you should hydrate these patients properly. The diet, you should avoid any things which delay the gastric emptying. These include, the diet should be low in fat and low in insoluble fiber. These patients should be asked to avoid alcohol, smoking, and carbonated beverages, and you should maintain an optimal glycemic control. So, in patients with mild to moderate gastroparesis, you can give them multiple small 5 to 6 meals a day, which are low in fat and fiber. Basically, small particle diets are preferred. Now, in those patients who are having severe vomiting and they are not able to tolerate solids, it's better to go for a liquid diet. And those patients who are not tolerating in this will have to go for a feeding tube. Initially, they recommend that there should be a nasojejunal tube placed for a few days, and based on the response, you can go for a peg jejunal feeding tube. In those patients who are not able to tolerate diet and having severe malnutrition, that is a group of patients who might require an initial parenteral nutrition. Apart from these, you have to go for correction of electrolytes, vitamins, and minerals, which can be oral in mild patients and IV or parenteral in refractory cases, and you should have a periodical assessment of these patients. Now, coming on to pharmacological therapy, we have got three groups of medications which use. One is those medications which accelerate your gastric emptying, medications for nausea and vomiting, and medications for relief of visceral pain. So basically, prokinetics are used in patients with gastroparesis who have not responded to dietary modification, and these are preferably administered 15 minutes before meals. So, if you look at what are the drugs available, I think most of the drugs these include dopamine antagonists like domperidone, which has been used 10 mg thrice daily, and in two studies they have shown that the response rate of domperidone is around 50 to 60% in these patients with domperidone. But it's very important. The side effect is QTC prolongation, so you should do an ECG before initiating this. Metoclopramide has been used extensively in these patients, and in a randomized study in which they compared domperidone and metoclopramide, both were found to be equally efficacious. Other prokinetics which we use include levosulpiride, citalopram, and etopride. All these have also been shown to be effective in improving the gastric emptying. The latest one which is being used is a prucalopride, and which is a 5-HT4 agonist. There is a recent placebo crossover study in which they have shown that prucalopride at 2 mg per day has been useful in both the improvement of nausea, vomiting, and also the quality of life. So, in the other group of medications is antiemetics in patients with persistent nausea and vomiting. These include phenothiazines and 5-HT3 antagonists like ondansetron, granisetron. It's very important that these medications also prolong QTC. So, in those patients who have hypokalemia, hypomagnesemia, bradyarrhythmias, you should always do a ECG monitoring to look for prolongation in QTC. Newer antiemetics have been there, including antidopaminergic like clibopride and the NK1 tachykinin receptor antagonist. These have been shown to give improvement in almost one third of patients with nausea. The third is pain. We should avoid opioid painkillers in these patients. The two molecules which have been used include tricyclic antidepressants, mirtazapine, and even pregabalin. So, mirtazapine decreases the symptoms of nausea, vomiting, and pain. There was a study called the NORIC trial in which they looked at nortriptyline versus placebo for symptom relief, and they did not find any improvement in the nortriptyline group when compared to placebo in improvement of nausea, bloating, or fullness. And the major other side effect which can happen is decrease in the gastric emptying. The other molecule which have been used is mirtazapine, which we know is an antidepressant with central adrenergic and serotonergic activity. It is very efficacious in nausea and vomiting. And in a study with Mahmood et al., they showed that at 4 to 6 weeks there was a significant decrease in vomiting and increase in body weight in these patients. A recent network analysis has been done on gastroparesis in which they look at 29 trials in these patients, and they found that clibopride was first in efficacy followed by domperidone. No other drug was superior to placebo. And two classes of drugs which were very efficacious include the dopamine antagonist and the tachykinin 1 receptors. And if they looked at the individual drugs, then metoclopramide was ranked first for nausea, fullness, and bloating. So in the other, if these patients you have done a nutritional thing, antiemetics, prokinetic, and there's no response to therapy, then you go for intervention therapy. This I won't touch because Dr. Puri will be talking on this. And in other groups, the other two modalities which are there include gastric electrical stimulation in patients who have got refractory nausea and vomiting and who have not had pain. And this has been approved for patients with refractory, but the data of multiple RCTs have been done, the results are very mixed. Surgery is done in patients with refractory gastroparesis, which include feeding jejunostomy and venting gastrostomy. So, if you are looking at a patient with gastroparesis who is having predominant nausea and vomiting, first you will go for a dietary modification. In patients who have not responded, we add a prokinetic, an antiemetic, and in patients for pain modulation, you will try look at mirtazapine. In patients who are having abdominal discomfort, it's the same. You have to go for dietary modification. You have to avoid opioid medications, and in patients you will have a significant thing. We can add mirtazapine. So I conclude by saying that gastroparesis for diagnosis requires typical symptoms, delay in gastric emptying, and absence of mechanical obstruction. The management depends on the severity of symptoms. In mild intermittent symptoms, initially dietary modification. In moderate to severe patients, we add prokinetics and antiemetics. And in patients who are refractory to medications, we'll go for IV nutrition, we go for enteral, parenteral, and other intervention therapies. Thank you.
Thank you, Nitesh, for excellent presentation. So invite questions from the house. So till we getting question, I just want to ask one question. What is your experience regarding one difficult scenario, that is malignant gastroparesis or malignant associated gastroparesis? Which drugs to be used? Because these patients are usually quite sick and have got refractory symptoms, and their lifespan expected is very short. So what is the best drug to treat their symptoms?
Which you are talking
Malignancy associated gastroparesis.
about? Malignancy.
Yeah, it could be CA pancreas, CA gallbladder.
Yeah, basically, I think the main treatment what we have used is prokinetics only and antiemetics. These are the main two groups, and the most important thing is that most of these you have to be very careful because we use a lot of domperidone. But I have seen that before using it, it's very important that we should give a QTC. And for these patients, especially with severe nausea, the newer neurokinins, especially apretinine, has been used a lot.
Sir, my question is, what is the role of sustained release prokinetics in the management?
See, basically, I do not use a lot of sustained release because I feel the best delivery for a prokinetic will be before 15. What is recommended is you should give it 15 minutes before the meals.
Thank you.
Any questions from the chairpersons? Any comments?
Hello. So I have basically two questions. You told that prior to document gastroparesis, it is mandatory to do EMG and as well as antrodural manometry to differentiate between whether it is due to myopathic cause or neuropathic cause. Really, is it mandatory? Because these two modalities, most of the centers, it is not available. My second question is that does differentiating between myopathic or neuropathic cause, does it have any clinical implication from medical treatment point of view?
See, basically, it is like for diagnosis of gastroparesis, you require a scintigraphy
Yeah.
or a breath test. You do not require this. But if you are looking at what is the cause, in that group, if you are not finding any cause, then you further evaluate to look for what is the myopathic or is it a neuropathic, and then you evaluate further to look for any what are the causes, and then based on that. So that's and anyhow, if it is idiopathic, the treatment won't change.
Thank you.
Nitesh, can I have a question?
Dr. Bimal, he said the role of intradural manometry. So sometimes it's not the only stomach which is at fault. Small bowel also may be involved. So when you do intradural manometry, you have an idea about the small bowel or duodenum. So in case you are offering some surgical therapy and your small bowel is at fault, then simple gastrectomy can lead to a disaster.
Thank you, Dr. Nitesh.
Can I have a question? Sorry, last.
Sure. One last.
Nitesh, just the practical things that we face in our patients of gastroparesis, because many of them may also be diabetics, is the delivery of drugs. because the stomach is not emptying. Many of them are on sustained release preparations, whether they are diabetic drugs which are sustained release, or they may be PPIs. Like we know our PPIs are absorbed in the small intestine. So how do you overcome that? Because the more poorer the diabetes control, the more poor. Do you switch them to insulin temporarily? Do you give mouth like oral releasing drugs? How do you manage that part
Yeah,
of it?
basically in those patients who are having very severe symptoms, and especially the diabetic control is very important. And I think the most important thing is if your diabetes is not well controlled when with bad gastroparesis, these will have a further worsening. So I think better to avoid these sustained release, I think, in these groups.
Thank you. Now, may I invite the next speaker, Dr. Rajesh Puri? I think he needs no introduction, one of the leading therapeutic endoscopists in the country, and he will discuss about the role of endoscopists in the management of gastroparesis. Dr. Puri, please.
Good morning, everyone. Would like to thank Dr. Khurana for the kind introduction and would like to thank INMA organizing team, especially Dr. Srihari for giving this opportunity. I think this topic require more studies, more thought process because it is not as simple giving the prokinetic drugs. And I'm very sure Dr. Nitesh Pratap will be agree when you give the medical treatment you can give for 2 months, 3 months, 4 months or 6 months. Drugs has tachyphylaxis, drugs has a side effects of the black box warning. And even same with the endoscopic treatment and same with the surgical treatment. So I think there's a lot of thought process required to understand the pathophysiology and you may be able to end up doing 2 or 3 type of combined treatment rather than the single treatment. And the another important thing is the selection of the patient, which is the crucial for management of the gastroparesis. So I'm going to talk today about the endoscopic management, how to select the patient, what is the technique and the outcome. So few slides I have a overlapping with Dr. Nitesh, and gastroparesis is defined as symptoms of gastroparesis in the form of postprandial fullness, satiety, nausea, vomiting, bloating, in the absence of mechanical gastric outlet obstruction on endoscopy and patient has definite gastric delay in gastric emptying studies. So three important symptomatology is important. Second, there should not be a dynamic obstruction. And third, patient should have a definite delay in the gastric emptying on scintigraphy. Before going to the management, it is important for us to understand because stomach is a neuromuscular organ and in the corpus the interstitial cell of Casal which act as a pacemaker and they propagate the slow wave that is 3 cycle per minute, and along with the plateau potential there is an action potential generated and these waves migrate the food from fundus to the corpus and to the pyloric antrum, and pyloric antrum contract and push the food to the duodenum. So this is the normal thing. So when we eat food, what happen is there's a fundus relaxation and food accommodate in the fundus. And once the fundus contract, there is the enteral filling and the mixing that churn the food and make it into the small particle. And with the enteroduodenal coordination, this is also very important. Here, not only a problem in the contraction, but there should be a good coordination with the enteroduodenal coordination that empty the food. So this is the normal. What happens in the gastroparesis? Either there is an impaired fundic relaxation or there is a gastric dysarrhythmias. The gastric motility, the body corpus motility is not either there is a brady gastric arrhythmia or there is a tachy, and patient might have a pylorospasm. And as I said, beside that, there are other factors in the form of drugs. So we should find out before subjecting the patient for any kind of therapy, either a medical, surgical, or endoscopy, which out of these three play an important role. There's a possibility in one patient, all three factors are playing, or in a patient, one factor is playing. That's why there is no single test which can say this is the cause of gastroparesis, and this type of therapy patient is going to respond. In contrary to achalasia, when we see you do a myotomy and patient respond very well. Here, when you do an endotherapy, you may see the gastric emptying improve, but the symptomatology is not improving because rather than only a pyloric spasm, there is a possibility patient might have a poor gastric enteral hypomotility, or patient might have a problem with the fundic relaxation. So I think we require more data, we require more studies to find out, and I think not only a single test which can give all these three answers. And once we know a predominant cause of gastroparesis, we can address that and we can give benefit to the patients. Regarding the etiology, I think Rinkesh has discussed idiopathic is the most common cause in the women with the middle aged. Diabetes is another important cause post surgery. I think that is very important. And another thing, patient who underwent a esophagectomy with the gastric pull-up, where the scintigraphy and these tests has no relevance. In post-surgical status, the enterodural manometry or the scintigraphy, they are not as accurate as it is seen in the patient who has a normal stomach. Or the medications are important cause. When the patient is on the multiple drug, it is very important to understand which one of the drug is causing the gastroparesis. So how do you diagnose, Dr. Nitesh has discussed, but most important is stop the medication which causes the gastroparesis at least 48 to 72 hours before. Test to be done when the patient sugars are uncontrolled. If there is a hyperglycemia, this patient has an artificial gastroparesis, an upper GI endoscopy to be done to rule out the dynamic obstruction. And after that, the scintigraphy for the gastric emptying for the solid is the gold standard. Normally, in a normal person, it should be less than 10% at 4 hours. But if there is a residue is more than 10%, these patients are labeled as a slow gastric emptying or gastroparesis. And depending upon if it is more than 20%, then it is called as severe gastroparesis. Wireless capsule motility testing not commonly done. I have no experience. Similarly, the breath test has been used, but again, I don't have any experience about this, and that is not the standard of test to diagnose. So most important thing is symptomatology, endoscopy, followed by the gastric emptying study by scintigraphy. If the food residue is more than 10 to 20%, these patients are called as gastroparesis. What can we do in endoscopy? We can do the endoscopic botulism injection. We can do the transpyloric stenting, pyloric balloon dilatation, and the gastric paroral endoscopic myectomy. I think this slide I have already discussed. I said in gastroparesis there is impaired fundic relaxation, gastric dysarrhythmia, and pylorospasm. And what endoscopic therapy can only direct about the pylorospasm, they are not addressing the fundic relaxation or they are not addressing the gastric dysarrhythmia. So that's why the result of G poem or we talk about surgical or medical treatment is not 100%. Patient shows symptom improvement but not in 100% in contrary to the achalasia cardia. That is very important for us to understand. So the most important question comes how to select the patient. How can we find out? As I said, no test is 100% to say these are the causes of gastroparesis. So selection of the patient is most difficult. When we talk about the botulism toxin, it can be used as a therapy or for selecting the patient for endoscopic treatment. So there are 15 studies, and out of 15, 13 are open label studies which shows that botulism toxin given in the dose of 100 to 200 international unit shows partial improvement for 6 to 8 months. But these are the two randomized sham control trial, and both the sham control trial shows that there was no difference between intrapyloric botulism and saline injections. So the question is, botulism is not the standard of treatment. It can only be done, in my opinion, in elderly people who are not the good candidate for long-term medical treatment or endoscopic or surgical. When we talk about the enteropyloric stent, again, this concept was given by Moin Kasab. And the problem with the enterodural stent is for how long you are going to keep the stent. The gastric motility migrate the stents. You have to stitch the stent. It is more costly treatment. So again, this is also not the standard of treatment. In clinical practice, these are the few case reports, but this is not the standard of treatment for gastroparesis. So I think G-POEM has certain role. The only thing is how to select the patient. Though it can be done from the greater curvature route or the lesser curvature route. As I said, the selection of patient, this is from the published in the Gut 2022, a moderate to severe symptoms of gastroparesis, preferably in the form of nausea and vomiting. Patient who has a pain as a predominant symptoms, which is the most important cause is sensory problem, is not the candidate for the G-POEM. Solid phase gastric retention of more than 20% at 4 hours. Another important thing, when you do a gastric emptying, people, because of the shortage of the time, do for around 90 minutes or for 2 hours. That doesn't give the accurate result. It should be done for 4 hours at least. And failed gastric electrical stimulation or pyloric stenting or botulism toxin. Here they have treated as a partial treatment. This is the algorithm which is given by Moin Kasab in CGS 2020, and I think that is a better criteria to select for endoscopy. Those patients who are refractory gastroparesis, which we have talked, along with no major abdominal component, no major psychiatric comorbidity, no uncontrolled diabetes, patient is not on narcotics and prior clinical response to botulism or balloon dilatation. And on endo flip, if the pylorus distendability is less than 8 to 10 millimeter of mercury, on enteroduodenal manometry, there is a no enteral hypomotility. If you find out these, that indicate you are mainly dealing with the pylorospasm, and these patients can be benefited with the endotherapy. So what I do in my clinical practice, because there's no guidelines, so pre-procedure I always give a shot of antibiotics. I check the endoscopy at least 2 days prior, because there's a lot of food residue in the stomach. We clean it, we keep the patient on the liquid diet at least for 2 days. And pre and the post procedure we give PPI at least for 4 weeks. We keep the patient in the hospital for 1 day. Liquid diet we generally start after 4 to 6 hours, and soft diet from the next day. No need to check the endoscopy or fluoroscopy as we were doing. And I think that learns over a period of the time. Once you have done around 40 to 50 cases, you know that you on endoscopy table, you know that you have done the closure effectively, then you don't require these patients for this. But yes, definitely the gastroparesis cardinal symptom index as well as gastric emptying study to be done at least 8 to 12 weeks to know is your endotherapy has given benefit to these patients or not. I think concept is like a poem. You do endoscopy, clean the stomach content, inject submucosal injection in the site of submucosal injection on the greater curvature 4 to 5 centimeter proximal to that, and you do an incision. Either you can give a longitudinal incision or you can give transverse incision, tackle both the margins and go inside the tunnel. So that is very important. The most important thing in the tunneling is you stay very close to the muscle and keep on coming outside to ensure that you are going in the right direction. Once you reach to the pylorus, you can see the perpendicular duodenal fold come. At this juncture, it's very important you inject saline. Make sure that you should not injure the duodenal mucosa. That is very important. And while doing the myotomy, it should be short, and you start from the duodenal side to the proximal by using the insulated knife to prevent the injury to the duodenal mucosa. These are the few important points, and the closure can be done either by the clip or by the endo-suturing device, because sometimes the stomach mucosa is thicker in comparison to esophageal mucosa. Clip alone are not sufficient. In these cases, you may require to do this. So few important points: do not extend your submucosal dissection beyond pylorus, risk of the duodenal mucosa injury. IT knife, because it is an insulated knife. Short myotomy, only do a myotomy of pyloric ring. People has done the double myotomy, or people has done the myotomy at 5 o'clock and 7 o'clock, because sometimes these fiber reunite and patient comes with the same symptoms. And try avoiding the bigger penetrating vessels, because the risk of the mucosal ischemia is there. Double pylorectomy, if the patient shows initial response and patient again come back with the gastroparesis, you can do anterior myotomy also, that is on the lesser curvature side and at least 4 centimeter proximal to the pyloric antrum. So this is the short-term results published in Annal of Surgery 2018 of 100 patients, 3-month follow-up, and overall GCSI score shows a significant improvement. 4-hour gastric emptying again show a significant improvement, and 1/3 of the patient shows normal 4-hour gastric emptying. This is the multi-center international prospective trial published in Gut 2022, and there were 5 centers, 75 patients completed, and the primary endpoint was one score decrease in the GCSI with a more than 25% decrease in the 2 subset at 12 months, and it shown that roughly around 55 to 60% of the patient shows response. What are the predictor of response? That is again important thing. Patient who has a GCSI scale of more than 2.6 before procedure or the gastric retention more than 20%, these patients shows better with the endotherapy. There is a sham group study with the G-POEM as I shown in the botulinum toxin. This study shows that in comparison to sham, G-POEM shows a significant improvement up to 70% of the patient. And when these sham patient was overlapped with the G-POEM, again these patient shows a significant improvement. So this is a 1-year follow-up of G-POEM in a refractive gastroparesis. The clinical success was in 61%. We have a follow-up of 3 years and follow-up for 4 years. Again, the clinical success is from 65 to 78%. When we compare gastroparesis with the surgical pyloromyotomy, the success both for the gastric emptying as well as GCSI score are equal. Adverse event are same with the pyloroplasty, but with the pyloromyotomy, the adverse event in the surgical group was more in comparison to endoscopy. So ladies and gentlemen, to summarize, one of the most important thing which I feel, which is we are still lacking a right selection of the patient, which is the single most important factor for determining the success of either a medical treatment or endoscopic treatment or surgical. G-POEM is equally and safe effective as surgical pyloroplasty. G-POEM is more effective and safer than surgical pyloromyotomy and gastric stimulations. But can symptomatology can decide? Yes, in adaptic patients, if there's a predominant nausea and vomiting, they shows the better outcome. In idiopathic patient, bloating and the satiety symptoms, these group of the patient shows better response. As I said, there's no single test which can decide which patients can be subjected to the G-POEM. I think you require a combination in the form of impedance planimetry, intradural manometry, or MRI to know the motility of the stomachs, role in identifying the subset of patients who are optimal candidate, and especially those patients who has a pylorospasm. These patients shows a very good response to G-POEM. I think the double pyloromyotomy deserve further studies because these, as I said, 65 to 71% of the patient shows response. So we don't have a data to say that when you have done the pyloromyotomy from the one side, is it adequate or not? So I think we require more study. Thank you for the patience hearing.
Rajesh, if we do not have with us electrogastrography and we don't have endoflip, can we take up such patient for such G-POEM? A lot of centers don't have these things available to them.
Yeah, I think Dr. Khurana is a very good question, and this is a practical problem which we encountered. So as I said, what we are relying today is on the gastric emptying study and the symptoms. We have only this. I talk about the ideal test. Today we can only rely on the symptoms of gastroparesis, endoscopy, rule out the mechanical cause, and on the gastric emptying study, if patient has a gastric retention more than 20%, you can take these patients. But the only thing we should make patient clear, there should not be 100% improvement in the symptoms of gastric emptying because we don't know, is it the pylorospasm is a predominant factor or the fundic relaxation or the enteral hypomotility is the cause. That is very important to talk to the patient.
Rajesh Ji, Mohan Prasad here. So brilliant talk. And I have two questions. One is, do you have experience on antroduodenal manometry? That's number one. Number two, what is the role of electrogastrography in with the high GMAT scores? Would they assist you in selecting patients? What's your experience?
Yes, so I think it's a very good question, and we have Dr. Srihari, Dr. Ghoshal, and I will mention Jubin is my colleague, and he invented a new intradural manometry, because the problem with the intradural manometry, which I understood, because patient comes to us once, my colleague, either Bimal or the Jubin, says this patient can be benefited with the GPOM, do it. But intradural manometry, yes, is one of the important aspects where you can know about the pylorospasm, you know the gastric motility, and it is going to help. So I think Jubin has invented a new catheter which is going to help, and Dr. Ghoshal is there to give more highlight on this. So generally we don't do in the practice the EGG.
Uh, I have a question. In the articles which you showed where the success rate was 65 to 70%, in the sub-analysis, I think it was the post-surgical groups who had probably vagus damage and not the primary and idiopathic gastroparesis who had a 70% response.
No, I
Am
agree,
correct?
and as I
Yeah?
said, endoscopy is not the standard of care. I just one line message. No single therapy is standard of care, because we don't know the exact. Is it the fundic relaxation is the important problem in the patient who is presented with the gastroparesis? Is the hypomotility or the pylorospasm? And that's why we don't get the result which we are expecting.
No, I think, like you said first, when you started off patient selection, so I think if we select the ones who've got gastroparesis post-surgically, like somebody who's had an Ivor Lewis or any other gastric surgery which may have caused this gastroparesis, I think those are the patients who will do well with GP.
Yeah, if you look at the anatomy side, those patients where there's a vagus injury, there's a three problem happens. One is a pylorospasm, second is a antral hypomotility, and gastric fundic. All three are affected. It is not only the pyloric spasm which is going to happen. In the vagus nerve injury, all three components
But
are
like
affected.
somebody in an Ivor Lewis, the fundus goes away, so that is not an issue.
I like to interrupt here. Actually,
Just
sir,
one second. See, what happens is intradural manometry is a very good test. We have done more than 250 patients. In fact, Dr. Sanjeev Sachdeva's thesis was on intradural manometry. And what happens is it is a very good test because it gives you amplitude of contraction in the antrum. It gives you pylorospasm. It gives you duodenal contraction. It gives you intraduodenal coordination. Now, what happens is even there are studies where they showed that if you have a pylorospasm, if you inject Botox in them, they improve. If you don't have pylorospasm, Botox doesn't help. Same will apply to GPOM. EGG we are doing regularly. In SGPGI we have done about 100 or more. In Apollo we have done till now 600 EGGs. A reasonable test, but what I think is it will require multiple tests to evaluate a big organ such as intradural manometry, gastric emptying study, and EGG together.
Thank you, thank you. I think I talked the same thing. No single test which is.
We are running short of time, Dr. Rajesh. Thank you so much for excellent talk. Thank you so much.
Thank you.